Well, good morning. It is a tremendous pleasure and honor for me to be invited to be a speaker at the annual conference of Ukrainian Association of Neurosurgeons 2021 version. I want to thank all of you, organizers, and especially Roman Ilyuk, who is a dear friend who we actually go back knowing each other almost 2 decades when Roman was my fellow when he visited the United States for approximately 4 months. And we worked closely together, and it was just an exceptional time. And he has developed into such an amazing surgeon, colleague, and friend who I look forward to spending time with again. I had the pleasure of hosting him again about 5 years ago. And we once again had a briefer time together, but it was absolutely stellar. I hope someday to meet many of you in person, and hopefully we can all get together for a meeting. And I would extend an invitation to any of you. If you'd like to spend time with us in the United States, we would love to host you as well. So my first talk is called Scoliosis 2.0, the intersection of personalized medicine and spine surgery. And this is a talk that I put together to address some of the changing issues that we've seen in the world with spine surgery. I have no relevant financial disclosures or interests related to this topic. My objectives are to introduce the concept of custom spinal implants, and then to review the advantages of custom spinal implants with you, and then to demonstrate some real-world applications of artificial intelligence and how I apply it in my practice today. So what do we mean first by things such as custom? Well, there means many things to many people. Robotics, that's a huge buzzword in hospital systems today. Everyone wants a robot, but what do the robots really do? Well, obviously they don't do very much from our point of view. This is a robot I've used, the Lorenz Walter, which is basically an articulated arm that locks where you tell it to go. The FDA, the US supervisory body for medical devices and drugs, refuses to allow any robot to autonomously do something. So for instance, if you're going to use a ROSA robot to put pedicle screws in, you still have to drill the hole yourself. The robot's not allowed to do that. So it really is in some ways a little misleading. Things that I believe that are more to the point are 3D printing. We can 3D print devices for patients now that are personalized and customized. And then we have this whole idea of precision medicine. So genomics and proteomics, which are very nascent but important in certain the field of spine. I think we're going to see genomics and proteomics become more important. Perhaps there'll be certain patients who would not benefit from a fusion and will know that, or will only benefit from a certain type of fusion. So are these gimmicks? Are these things just designed to sell more devices and products and move on to the next thing? Is it, as Voltaire once said, there's nothing new under the sun, or old wine in new bottles, or is this truly something new? And I think there are some things that truly have changed the game for us, but we have to be selective in what we talk about. So what is one reality of personalized medicine for me? Well, that involves custom implants and custom implant sizing, implants that are made specifically for one particular patient at one particular time. And those could be anything ranging from interbody devices to, as I'll show you in a few moments, rods for correction of spinal deformity. But custom implants definitely lead to a shorter intraoperative duration and improved precision of our preoperative goals. Here's an example of a very typical case for me. So this is a patient who has a complex thoracolumbar issue and a revision surgery. And obviously a case like this, we're looking at many hours in the operating room, but if we can do anything we can to shave that time period down, we're going to be giving a great deal of value to that case and that patient. Adult spinal deformity is a bigger and bigger issue for us. It's becoming more and more prevalent as the world ages. We have the graying of America, and you have a similar problem in Ukraine, which is low birth rates and a higher percentage of the population who is aging. So it is a reality for us. And when I was still in training in the 1990s, we've changed our attitudes to age compared to what thresholds we use for surgery. One area of spinal surgery that's incredibly important to me is what we call extreme elderly spinal surgery. In other words, operating on patients who are 80 years or older. And that's becoming much more common for us and is, even in the realm of complex spine surgery, much more a reality than a fantasy. So I'm going to show you my experience with one particular platform, which the best I can tell is rather unique. And that is a platform developed by a company called Medicrea out of Bordeaux, France, which was recently acquired by Medtronic. So if you wanted specific details on how to implement this in your practice, you probably would need to talk with your Medtronic representatives locally. But what this is a whole platform of instrumentation, as well as artificial intelligence and planning tools. So for instance, I have the planning tool as an app on my iPhone and also on my laptop. And what this allows us to do is interact with the engineers at the company and allows me to take a patient's preoperative status in terms of key parameters off of x-rays, and then tell the company what I would like to achieve for this patient as my postoperative goal. And then you can see in this screenshot here from the app that various parameters such as pelvic tilt, pelvic incidence, sacral slope, and on, but especially sagittal vertical axis, or SVA, are extremely important parameters for us, such as sagittal imbalance issues. And I'm able to, in the first column, have the patient's preoperative data presented. And in the second column, I can tell the company what I want to achieve as far as my goals for correcting this patient. In other words, I'm dialing in the correction. So here's a typical preoperative workup. We use what we used to refer to as long cassette films, but really what they are scoliosis series that are stitched together digitally to have the entire spine with some fiducial markers on the skin. So it's a very simple, cheap data acquisition that's then implanted into the program, imported, so to speak, digitally. And then this allows for our sophisticated preoperative planning to occur. So what you're seeing here is a typical preoperative plan design. What I've told the company is what I want to achieve numerically, and also how I'm going to achieve it with basically the osteotomies and types of devices I'm going to use. I am a heavy user of interbody devices, such as T-lifts, transforaminal lumbar interbody devices, because those allow you to give very nice, precise corrections. And sometimes we'll do multiple of those, but you can do Smith-Peterson osteotomies or pedicle subtraction osteotomies, whatever you may need to do to correct kyphosis and the coronal imbalance. And once all that is put in, the company then devises what the postoperative product, so to speak, will look like, and also generates, as you can see with this blue line, a rod. Now, they not only generate a rod, but they actually generate the actual rod based on those angles. So in other words, the Medicrea Corporation takes my data plan, takes my plots, and then makes a titanium rod for me that is exactly shaped for the patient, which is then sent to me, and then we sterilize. So that is a huge, huge time saver because you're no longer cutting a rod and bending a rod intraoperatively. And what we do also with this system is a passive correction of the patient. What I mean by that is that the Medicrea system is a posted rod as opposed to a polyaxial head rod system. So posted rods were the initial types of pedicle screw systems that were very common back in the late 80s and early 90s, which got supplanted and replaced by and large by rods that are polyaxial heads. But what the posted rod system allows you to do is put the pedicle screws in first and then bring the rod into the field and then start to connect the rod to the various posts and tighten sequentially the nuts. And what that does is elevates the patient or brings the patient to the rods. And then that is how we passively correct. So we don't have to actively lever the patient's spine with persuader devices and wrenches. Instead, we're able to just passively correct the entire system. So this is an example of a complex revision case of mine. This is a patient who's had 2 prior spine surgeries and now has new pain in the upper thoracic region about 5 weeks postoperatively after she fell. You can see what her problem is here. She has a severe proximal junctional kyphosis, which obviously is not only causing severe pain and disability, but is putting her at risk of paraplegia. So it was a very easy matter for the computer system to come up with a new rod for me. And you can see the new rod generated in the blue line there. I placed my various surgical plan approaches in terms of where I was going to do osteotomies. And then this literally saved me probably 2 hours of operative time on this very frail patient. And here's my 1 week postoperative view. So that all sounds very good, but there's a whole other facet to this type of program that is equally important, and that's prospective and postoperative planning. We're able to then place postoperative films of the patient into the system so we can then monitor the patient postoperatively to check their angles and see how they're healing, and we'll get early failure detection, early warning, so to speak, if they start to develop a new proximal junctional kyphosis, for instance. Another very important part about these types of data sets are that they allow us to have personalized data analysis. In other words, I'm able to look at myself as a surgeon personally to see how I am doing with all my patients and keep very close track of many different parameters. So just as the horse that's very fearful of what it might have touched in the surf here, we cannot fear our results. We have to, if we want to become better surgeons every week and every month of our lives, we need to constantly be critical of ourselves and especially look at our failures. Because knowledge is indeed power. Unfortunately, this lady is an example of an epic tattoo failure where the words are misspelled. So I find these always interesting to keep track of, because as probably in your culture as well as mine, tattoos are just so prevalent, especially in the younger generation. And we see some pretty amazing messed up tattoos. But back to what's more relevantly important, individualized surgical analytics. So what I'm going to share with you is my experience of my first 39 consecutive cases with the Metacrea platform and what I've been able to do just very easily with the data set that's already in the system. And this allows me to compare my preoperative plan to my actual degree of correction. And then I'm able to drill down on various aspects of it. And one aspect I found very interesting to me was looking at my first 19 patients versus my second 20 patients that I did chronologically to ask the question and see if I can get a handle on whether or not I improved. Was this system making me a better surgeon? So first off, this is the instrumentation overview, where there are just scatter plots demonstrating the most common levels of instrumentation used. Typically, I'm doing anywhere from T10 to L5 type of construct is a very common one for me. So the next sets of slides will show violin plots of various parameters and how close I was able to achieve my correction. In the red is the preoperative patient data. In the blue is what the plan devised. And then the green, which is most important, is what I actually was able to achieve with the patients postoperatively. So we can look at things like pelvic incidence and lumbar lordosis, i.e. the sagittal imbalance, and we can see that I was able to improve it, but still not as close as a plan would have dictated. And I can now begin to ask myself, well, why did I not achieve it as well as I thought I could? Pelvic tilt, same idea. I actually improved pelvic tilt somewhat better than the plan in some cases. Spinal pelvic analysis, here is the first half versus the second half of my cohort. In other words, did I become improved as a surgeon in my ability to achieve the goals? And I think we can say yes, because you look at the violin plots of the first half versus the second half, I'm actually able to tighten up the violin plot, which shows I was able to approach more closely what my goals would have been. So I learned something by using the system. I improved by using the system after my first 19 cases. Here would be a different way of looking at it. This is looking at constructs 5 or less segments versus 6 or more segments. And we can see 6 or more segments are more complex, so the violin plots are more elongated. here once again is looking at chronologically first half data versus second half data. I was really pretty much able to, with pelvic tilt, to perhaps maybe mildly improve things, but once again, tightening the data plot, but it could show me some avenues of improvement for myself. And in a similar fashion, looking at pelvic tilt in patients who have 5 segments or less, or 6 or greater, and actually seeming to do better in patients getting a little closer to the mark with 5 or less, which would make sense because those are less complicated patients. And then sagittal vertical axis and thoracic kyphosis in a similar way can look at the SVA versus the thoracic kyphosis. And these are things, once again, that can point to aspects that I could potentially improve, and also ask questions as to, did these particular parameters much matter in patient outcomes? So analytics, extremely important to look at failure analysis. So if I'm failing to achieve certain goals intraoperatively, why is that? Well, in order to ask that question, you first have to realize what you're failing at. So this allows me to understand that better. It allows me to understand true data as opposed to simply eyeballing my data, which I think we're all guilty of, seeing what we want to see if we're just kind of casually perusing stuff, as opposed to really looking at the data in hard, cold light. Longitudinal success in a single patient, obviously very important to see how a patient heals, and this allows us to follow that. But also your longitudinal evolution as a surgeon, because it's obviously key to understand if you're improving or not as a surgeon as we go forward. This adds a new dimension to what we know as the quality discussion. And the quality discussion is one that is very important to us. It's a buzzword in the United States, and I'm sure in your country as well, as to what administrators, for instance, love to know. And it gives them bragging rights about how good their hospital system is. But I will caution you, as you become more developed with using quality discussions in these greater bureaucratic type of discussions, many hospital systems in the United States now farm this information out or ask outside vendors to come in and insert quality programs and then run their quality programs. So I never trust quality data that's brought to me from a system. I always like to generate my own, because you'll find out that in many of these systems, they're not sensitive to what is important to us as neurosurgeons. Many of our patients are orphan or near orphan status in terms of the numbers. So our numbers tend to get washed out in the greater data sets compared to patients who have, for instance, coronary angioplasties. So you want to always be able to defend your own good work with your own quality data numbers. And this is one way of helping you. Obviously, this is how salaries are set, and this is how funds are allocated to departments, and this is how we decide to build new operating rooms or buy microscopes, et cetera. So it's very important to us to understand quality. And this is one way to help yourself, and you can prove things to administrators that they would have never have thought of if you didn't show this to them. And it just boils down to, once again, being a discussion that matters. We've all been in meetings and really have been senseless to us about what's being discussed. So this is a way that we can rightfully push our own agendas to show what is truly important to us as neurosurgeons in the 21st century. So I'll stop here with my first talk, and I thank you very much for this opportunity. And I look forward once again to interacting with all of you very soon. Thank you.